Thank you, Debbie. And it is a pleasure to be here. And this is going to start out a little bit technical, but I promise you I won't labor that for you. Okay, but to give a little bit of background, and I'm also going to give my apologies because I think I know how to work this. Debbie gave me a 1-second talk on how to make it go. Yes, it does. Okay, so what we're going to try to talk about is arthritis, obviously. But we're not going to get into every little bit of arthritis because you can't do that in 20 or 30 minutes. I'm not going to talk about small joints. I'm not going to talk about your spine. I know you're going to have another talk about that soon. Hands are a very big part of arthritis and arthritis symptoms, but we can only do so much this morning. So we're going to talk about the big joints, and I'm going to show you some pictures of how it comes about, and we're going to talk about what causes the pain. Let me ask, can you guys see this? Would it be better if I stood over here? Is that better? And y'all can still see? Okay. So we're going to talk about what causes the pain, and that's where it's going to get a little bit technical for a short period of time. We'll talk about some of the risk factors, and we'll talk about what kind of treatment options there are. So what causes the pain in the joint? Okay, first of all, a synovial joint. Let me see if I get this right. Yeah, the synovium. The synovium is the lining of the joint, and almost every joint in your body is a synovial joint. Certainly the ones that move are synovial joints. The synovium is the lining. It produces the synovial fluid, and the synovial fluid is the stuff that's very slippery. It's the oil for the joints, if you will. The ligaments attach bone to bone. Tendons attach muscle to bone. So the ligaments are important. They're important to keep your joints stable. They're important to keep them from moving in ways that would damage them. The articular cartilage, that's the white shiny stuff on the end of a chicken bone is what I say all the time, because everybody, that's a visual for you guys and for me, but not for a lot of the young people. They have no idea what a chicken looks like, but they think it comes in a strip and fried. But and then the subchondral bone. Subchondral means below the cartilage, and the bone supporting the cartilage is a source of a problem if it starts to break down, because obviously if the foundation of your house starts to sink, so goes your house. Articular cartilage, the white shiny stuff, is compressively stiff. You squeeze it down, it squeezes back. And so it gives you that bit of shock absorbing that's important to keep your joints going. It's made up of hyaline cartilage. There's not a test at the end. But hyaline cartilage is the joint cartilage. It's the resilient, very specialized, and let me digress a second. Very specialized means that if you destroy it, it doesn't grow back. If you destroy a nerve, it doesn't grow back because it's very specialized tissue. But articular cartilage is usually where we think of as the first place that we see problems with arthritis. Okay, here's where it gets more and more technical for a couple of slides. The matrix. The matrix is the part of the cartilage that's made up of basically two things, two macromolecules, if you will. Type 2 collagen and something called aggrecan. I don't want to delve into this too much, but aggrecan it's a type of a macromolecule that has a very, very strong negative charge to it. Now, anybody that's got any chemistry, water also has a negative charge. And to give it, you have a problem. Chondrocytes, what are they? They're the cartilage cells. Now they do good things, and when they start getting arthritis, and let me apologize, your handout's not water content to some extent, which can attribute to why people get a little bit shorter. We stand more as adults, and so the compressive force is there. But the cartilage loses some of its responsiveness to loading. So whereas before it went down and bounced back like a ball, now it's more like florist foam that you stick flowers in. You know, the green stuff you put your finger in and it doesn't come back. Your cartilage tends to, as we get older, it wants to do that more and more. As a rule, muscles get weaker. We're not as active. Ligaments get stiffer. So we've got less compressive response to loading, we've got weaker muscles, and we've got stiffer ligaments. So now all of a sudden we're a setup for some kind of a problem with a joint. And that's wherein lies the encouragement to stay active. Keep your muscles going, keep them loose, keep mobility in place. God made joints to move, and if you don't move them, they get stiff. Bone density, that's always a question. Interestingly enough, the harder your bones are, the more likely you are to get arthritis. And that's wherein lies this negative association with arthritis. Do you remember me commenting on subchondral bone, the bone that sits below the cartilage in your joint, and the stuff that supports the joint cartilage? If that's compliant, if that's a little softer, like it would be in osteoporosis, then it gives a little bit more. So it may not give you that injury. Think about it like this. If you jump off of a step or two and land on the grass, it's not nearly as uncomfortable as if you jump off a step or two and land on the concrete floor. So if you've got a lot of bone density, if your bones are very dense like concrete, then you have a little bit more risk for osteoarthritis. Osteoporosis is the grass. Now, those are not 100%. Okay? Just because you've got osteoporosis doesn't mean you won't get arthritis, and just because you have really strong, hard bones doesn't mean you're going to get it. Let me back up a second. If you have osteoporosis, it doesn't mean that you're spared from arthritis, because plenty of people with osteoporosis have arthritis. Just as much, if you are on your feet and you're stable and you're doing weight-bearing exercises and you're taking vitamin D and calcium and you're getting in the sun and all the sort of things that we tell folks to do, doesn't mean that you're going to get arthritis, but that there's a correlation. Anatomy. If you have, the classic example here is for the larger joints are hip dysplasia in kids, people that had a hip dislocation when they were born, scoliosis in your back. It wears differently. It's not set up the way God should have, or the way they were designed to set up. Something went wrong. You've got an abnormal wearing. I'm going to just show you a couple of pictures of that in a minute. X-rays are still the gold standard for arthritis. You look for bone spurs, you look for joint space narrowing. MRIs, they can be important. They're terrible to assess your arthritis. They just don't, unless you're missing the whole cartilage spot on the end of the bone, or you've got some type of a compression fracture where it shows some bruising behind it. They're not very good. They'll tell you the cartilage is thinning, but we're several years away from having really good MRIs to talk about arthritis. And then I said earlier, right now there's no blood test. There is for rheumatoid arthritis, there is for lupus, there's not for osteoarthritis. So, what are our goals in our treatment? And then we're going to go through some of the treatment in a minute. Well, number one is pain relief. Everybody in here has taken an Advil, an aspirin, a Tylenol, or something like that. Now, it wasn't because you thought it was going to fix your arthritis or fix your sore back or whatever. It was really the pain. And that's really a big goal in treatment of arthritis. We want to improve physical function. The idea is that if your knee is sore, and I can't tell you the number of times I hear this on a daily basis, I can't exercise, so I can't get the weight off, and that's why my knee hurts and is arthritic. Sort of. But staying active improves everything. Yes, it can help you burn more calories, but it makes you feel better about yourself. If you feel better about yourself and you're able to get out and do something and you've got something to look forward to, you'll tolerate a little discomfort a lot better. It's when pain becomes 24/7 that it's tough. It's tough to deal with. Unfortunately, unlike many other disease processes, we don't have a medicine that really treats, or I said a disease-modifying drug. It doesn't really treat the arthritis. They treat the symptoms. They treat the pain. They might improve your function, but they don't go back and fix what's already gone. So our treatments, if we drill down a little bit more, we go to non-surgical treatments. Physical therapy, obvious things there. Improve your mobility, improve your muscle strength, loosen your joints up. Bracing and heel wedges. Bracing can be very helpful, especially in knees. Not so good in hips. They work pretty well in ankles. Heel wedges, the idea there is that if you've got a worn out inside part of your knee and you put a lateral or an outside heel wedge, the first thing to hit is the outside of your foot. So when you step, it forces you to put more weight on the outside because it pushes you this way. Does that make sense? If it's the outside, you can put them on the inside so that the inside hits and you basically unload that affected compartment of your knee joint. Sometimes they work great, sometimes they don't work very well, but they're inexpensive and they're easy. You can put them in any shoes. There are no consequences to that. I will say you need to wear them in both sides, because if you don't, you're going to be off balance and then there's all sorts of opportunities for problems there. Injections. Everybody knows about injections. Get a shot, it works. Steroids help. They help because, as we talked about earlier, the cells in your knee start putting out these enzymes that cause more problems. And the way the steroids work is they stabilize the membranes and don't let those enzymes get released into your knee joint. They don't fix it, they just help settle down some of the inflammation. Most people know the visco supplements as either the rooster shot, the chicken shot, the gel shots. I dare say few of you know them as visco supplements or hyaluronic acid derivatives, but that's really what they are. And they can be helpful. arthroscopy. Sometimes arthroscopy is not the way to go because you go fooling around in somebody's knee that's already arthritic and all you wind up with an arthritic sore knee. Now, a lot of times you don't know. You don't know going in. The x-rays look fine. The MRI shows a torn cartilage. Their exam is a torn cartilage. You look in their knee and you go, uh-oh, this is not happy. Most of those people still get better. But knowing somebody has a bunch of arthritis is not the time to start thinking about arthroscopy. Maybe with an exception of your hip, and I'm not going to get into that too much. There's something called femoral acetabular impingement, where you kind of hit, the ball kind of hits on the side, and people are going in arthroscopically and shaving that off. I think the jury's still out. That hadn't been done but for a couple, 3 years, so long term it may or may not be a good thing. And then arthroplasty, that's your total joint replacement. We're going to talk a lot about that in a second. And then arthrodesis, that's a fusion. That's making the two bones grow together. And that'll stop the pain because arthritic pain is usually secondary to small amounts of motion. It's not normal motion, it's a rough spot, and usually as it starts moving less and less, it hurts more and more. And arthrodesis, very good in your ankle and your foot because the joint replacements are not very good down there. Knees, a stiff knee is a challenge on a lot of different fronts. Stiff hip is a very big functional problem. Sitting in a chair, getting in the car, just walking, you wind up making your back very sore. So that's not the primary goals. Total joint replacement is clearly the single most effective. And good news is the failure rate's about 1% per year. That's pretty good. The better outcomes in people that are over 50, probably because you got more sense. Now that I'm 50, I can say that. But you're a little more reasonable. You put joints in young people and they think, wow, my knee doesn't hurt, my hip doesn't hurt, I'm going at it. And they do. And you certainly have some consequences from that if you overdo it. It's better if you don't wait until you're absolutely debilitated. Total knee replacement, the best indicator of post-operative range of motion is pre-operative range of motion. If you're stiff going in, you've got to work to not be stiff coming out. And then stem cells, and somebody's going to ask me about stem cells probably. Interestingly enough, there's some guys there are multiple different centers. I've heard the fellow speak that's in Scottsdale, Arizona, and they're working on it pretty hard. And they have gotten to the point where they can make, you ready for this? Your fat cells turn into cartilage. Now, the problem is how do you get them in there where you need them? And it looks like hyaline cartilage. It looks like joint cartilage. But how do you get it there and how do you get it to stay? And we don't really know. They're working on that. That's been several years ago since I heard him speak, and I watch that fairly regularly. Nobody's got the answer yet. But at some point, somebody will come up with a way that will probably work. But it's probably not in our lifetime. I hope it is, but I'm not sure it will be. Okay, now we're going to very briefly, and I brought some examples and I'll show you some of these in a minute. Bearing surfaces. You've probably heard a lot about metal on metal. That was very popular about 40 years ago. And it was very popular about 10 years ago. It's not popular at all now because of the metal ions and all the stuff that can go along with that. And I don't want to talk about that too much. So most people are not doing metal. Some of these resurfacing hips, which actually there's one called the Birmingham hip, not because of Birmingham, Alabama, because of Birmingham, England, because that's where the gentleman sort of championed it and designed it. There's still some people putting those in. Metal poly. Poly is polyethylene or high molecular weight, highly cross-linked polyethylene, which is basically plastic that holds up well under wear. That's the standard. I think that's the gold standard. We go away from it. We go to metal, we go to ceramic on the poly, we go to ceramic on ceramic. It still comes back. That's still where that's the default mode. Now, and I'm going to show you this in a minute too. There's a new, and I say new, it's been out probably 10 years, called oxinium. And oxinium on plastic or poly is probably the thing to go, and that's what I'm using now. And that's the one, that's the only joint that I'm aware of the FDA has ever said it is good for this many years, and they're saying it's the 30-year knee. It is a ceramicized metal. So, and the company's propaganda says it's 4,900 times more resistant to wear than cobalt chrome, which is the normal metal. That's pretty good. The point is that your ceramic coffee cup is much slipperier than your metal pot. That's the best analogy I can tell you. The water runs off of it. It's wettable. The water runs over it. So the ceramics can be brittle, just like your coffee cup. This is a ceramicized metal. And I'd say, if you're interested, look that up, because there's a lot of information about it, and it's really pretty interesting. Then you can talk about total knee, partial knee. The CR is cruciate retaining or posterior stabilized. That just depends on which ligaments. Do you cut your anterior cruciate and your posterior cruciate? That's a posterior stabilized, or just the anterior cruciate. And then mobile bearing. There are knees where the plastic moves inside the metal, and some people feel like those are the greatest. Some people don't like them at all. Classic history, or a classic example of bad knees. No, this is not somebody in this room. This happens to be more in the outside or lateral compartment, and unfortunately it's both sides, and this poor lady has had a terrible time walking. I don't know that you treat that non-surgically. There's not a lot you can do for that. Let me go back to that one just a second. The concern when your knee is not kneed, if you will, or valgus, is that if it gets too badly, the nerve that runs right around here, when you straighten it up to fix it, you can stretch that nerve and wind up with a foot drop. So that's one where it took me a while to encourage her to do something before she had problems with that. Normal looking knee x-rays, so you can kind of compare that to that. We're going to come back to that arthritic knee in a second. Just a different one. This is just kind of what an x-ray, and these little things here are the staples. This is an immediate post-op, and good. I was like, oh, did I have the name on there? But I didn't. I cut that off. And you can see they have some arthritis on the other knee as well. You can see the bone spurs here. You can see the joint space narrowing compared to this one, although the outside compartment or lateral compartment is involved to some extent. There's that lady's knees again. Really lost the space. Even on this inside that doesn't look like it's so involved, I would submit that that's got a cavity there, or a concave point. You can look right there. That's probably a cyst. Then we jump on to hips. You can do a total hip. That just means you fix the cup and the ball. You can do a hemiarthroplasty, which is just the ball. And we do that a lot for hip fractures because it's not as involved. And most of the time with a hip fracture, you want to try to get in and get out and let them get up and get going. I'll go back to that for a second on the knees. Now let's just keep going. Arthroscopy of the hip, we talked about that a little bit. Relatively new technique. I say new, it's been around for a long time, but it's becoming more and more popular. And then you probably hear a lot on hips about anterior versus posterior approach. Well, you do it anterior and it's a muscle splitting. Well, that's true. Or you do a posterior approach and it's more involved. Well, maybe a little bit. There are no studies that show that one approach is better, safer, or you have fewer complications than the other. The anterior approach, not as many people use them because there are certain things that don't allow you to do an anterior approach. If you're real heavy, if you're real tall, you have to have a special table. You have to use the x-ray. There's an increased risk of breaking things because of the positions you have to put the patient in. So most people still fall back to the posterior approach. It's a good, proven approach that most people do extremely well with. And the head size, which I'll mention next, makes a lot of difference. Used to, and you may know some people that have had their total hip dislocate. That was much, much, much more common when we used 28 millimeter heads instead of what we use now, which are usually 36 or 40 or even 44 millimeter heads. Significantly larger, gives you more of an anatomic total hip replacement. It gives you more motion and more stability. And then I just touched on the dislocation part. So normal hip x-ray, arthritis, some here, Oops, this is the old one. Okay, so developmental dysplasia. This is what I was talking about earlier. If you see, if you look at this hip, that's pretty normal. If you look at this one, see how it's really high? And it's really kind of worn its own socket up here called a false acetabulum. So you bring this down, try to put it back in the same spot. You just leave all this up here and try. That's an anatomy risk factor for arthritis. All right, total shoulders, and we're almost finished. Total shoulders, partial shoulder, or reverse shoulder. Total shoulder is just like the hip. You do the ball and you do the cup. A lot of people don't do the cup part. It's called the glenoid because it's a challenge. It's tough, especially in larger people. It's a deep place. It's hard to get exposure. It does give you more pain relief, especially if you have arthritis there. If you don't have a lot of arthritis, and I did 2 hemi shoulders yesterday on people that are young but had terrible arthritis on the ball part, but the cup part was reasonably well preserved. You also put them at risk to how much you can lift. You really ought to not lift more than 30 or 40 pounds with your affected shoulder with a total shoulder. Hemi or partial shoulder probably doesn't matter. And then the reverse shoulder. Reverse shoulders are a fairly new treatment, and reverse doesn't mean we put it in backwards. It does mean that you put the ball on the cup and the cup on the ball. And the point is, and I think I got a slide of that, normal shoulder x-ray, arthritic shoulder x-ray. This is one of the guys that I did yesterday. See that big spur right there? But this is pretty well maintained. Now, we go in there and we look at that and make sure, but his was reasonably well preserved, and I think he's 39. And this is a total shoulder. This is a different patient, but total shoulder. You can see this little button right here. That's just so you can see, because this is a plastic cup in here. The reverse shoulder, you put the cup on the ball and the ball on the cup. And the point there is that if you've got a rotator cuff tear that cannot be fixed, you can't raise your arm very well. Some people do it, and that's a totally different topic. But if you can put this here, you can use your deltoid, which is the big muscle you can feel. You can power your shoulder. If you don't, if the rotator cuff attaches, here, and the bone is the acromion up on the top, which is the bone you can feel on the top of your shoulder. If you don't have the rotator cuff, then your deltoid muscle, which attaches out here, just pulls it up. So it bumps under the bottom of the acromion if you don't have a rotator cuff. But if you put the cup here and you put the ball here, now where your deltoid muscle attaches here will pull you up and you have a functional shoulder. Plus, a lot of people that have bad arthritis or bad rotator cuff tears that have been there a long time and have already got pretty significant arthritis. And so this has been a really good thing. It's not a panacea. It's not for everybody. Although some people want to do that, that's not the go-to for everything. That's what one looks like on a reverse. That's what the x-ray looks like. And then finally, we're going to do elbows very briefly, normal elbow x-ray. And yes, you can do elbow replacements, and they work pretty well. That's what an elbow replacement looks like. This is a lady that had broken her elbow years ago and had done fairly well and actually had very good motion until about, I don't know, maybe 8 or 10 months ago. And we injected her a few times, and it just kept getting worse to the point where she wasn't sleeping. And so, let's see, I thought I had her, well, I guess we missed it. I'm going to get you the other disc for the DVD. But the x-rays, this was her joint here is pretty destroyed, and you basically come in and this is more of a fixed bearing as opposed to your knees and your hips. This is connected together, and then that's the radial head, but you really just leave it alone. And she is extremely happy with this because she's had all this pain. She already had motion, good motion, so she probably lacks about maybe 10 degrees of full extension and has excellent flexion. So, summary. Pain, we talked about what you can do for it, what causes it. We talked about the risk factors. We talked about some treatments, and then the future, and that's the stem cell thing that we were talking about. That's new joint replacements. It's how do you do them? Do you do them MRI designed? Sure, you can. Nobody's doing a lot of the robotic stuff because the setup is so labor intensive. And if you don't get your setup just right, it's not like taking out your gallbladder or doing a prostatectomy or doing a hysterectomy with the robot. You've probably heard of the Da Vinci's. That's a different game because everybody's deformities are different in their knees and hips. So nobody's really jumped on that. We have doing questions.